Okay, hello everyone. Welcome to Advanced Echo Guidance for Tricuspid Transcatheter Atrial Repair Online Workshop. I'm Dr. Karen Fan from the Shanghai Trust Hospital. I'm the moderator today. And before we start, here are some housekeeping notes for the online workshop. The first, if you have any questions during the workshop, please feel free to input at the chat box in the Zoom meeting or unmute yourself to ask questions during the Q&A sessions. There will be around 5 minutes Q&A session at each of the topic. Second, during the workshop, please turn off your camera and microphone so that we can have more bandwidth and better Zoom video quality. The last, this online workshop will be recorded for internal use. So next, may I introduce our course directors, Professor Alex Lee and Professor Gregory Stigler. Professor Alex Lee is a professor of the Division of Cardiology in the Chinese University of Hong Kong and the director of Echo Lab in Prince of Wales Hospital, Hong Kong. And Professor Gregory Stigler is the director of echocardiography in the Prince Charles Hospital and also the professor of medicine in the University of Queensland. It is our honor to have Dr. Maurizio Termoso as speaker today. Dr. Termoso is a cardiac surgeon, structural interventionist from the Heart Center, Kirslanden, Zurich, Switzerland. And Dr. Termoso will be our first speaker. He will share the tricuspid valve anatomic consideration for TEER. Dr. Termoso, please.
Thank you, Karen, for the kind introduction. Thank you, Abbott, for organizing. And without further delay, I think I will start sharing my screen because as for every kind of intervention, but for tricuspid, even more important, the anatomical basis, to understand the anatomical basic is tremendously helpful to get procedural success. Why this? Well, because the tricuspid is a complex structure. There are several challenges. Some of them now have been almost overcome. Some of them are still open issue in the transcatheter treatment of the tricuspid valve. I like to divide the open challenging of the transcatheter tricuspid valve intervention in these 4 groups. As you can see, one of the 4 groups is related to the anatomy. The anatomy of the tricuspid valve presents several challenges, partially related to the axis. I mean, the angle between the vena cava and the tricuspid annulus, the anatomy itself, the dimension of the annulus, which is the larger among the 4 valves. Usually there are no calcifications. So if we think to, for example, to put a replacement device, we cannot do the same thing that we do maybe in mitral, where we use the calcification or in aortic during TAVI to anchor a device in the tricuspid position. Then there are a lot of vital structure close to the tricuspid, as we will see, like the right coronary artery, the atrioventricular node, the aortic valve. So it is surrounded from several important and vital anatomical structure. There is a 3-leaflet configuration. And then obviously the tissue of the tricuspid valve is more fragile as compared to the tissue of the mitral or of the aortic valve. So several challenges related to the anatomy that we can change. We can improve imaging, we can improve our clinical patient selection, we can improve our definition, but we cannot improve anatomy. We can just improve our device to accommodate the challenging anatomy of the tricuspid. Beside anatomy, it's also important to understand the pathophysiology. The most frequent etiology of tricuspid regurgitation that is usually treated with transcatheter method is functional TR, where functional means that's the main mechanism for the tricuspid valve to leak is annular dilatation. The annular dilatation of the tricuspid, and this is also related to its anatomy, dilate in an asymmetrical way. So the anterior and the posterior portion of the tricuspid annulus, which are the portion connected to the free wall of the right ventricle, so which are not connected to the septum, are the one that dilates. So the portion of the annulus connected to the septum usually at minimal modification when the right atrium or the right ventricle dilates, while the posterior and the anterior part of the annulus dilates the most. And this is the first determinant of tricuspid regurgitation in functional etiology. And then usually in a second step also valve tethering is then becoming more evident due to right ventricular remodeling. We may discuss the different etiology of right ventricular remodeling or right atrial remodeling. Obviously, if the pre-move movements is the right atrial remodeling, the tethering of the valve will appear just in a really late stage of the disease. If the pre-move movements is the remodeling of the right ventricle, then this will appear quite early. But in general, in functional etiology, we have always annular dilatation and some degrees of valve tethering. This is how the surgeon see the valve during open heart operation. So this is the so-called surgical view, which is also the one that we see when we perform 3D echo. Usually in 3D echo, we put the aortic valve at 12 o'clock, but actually what is done in what is the real surgical view as the aortic valve at, you see the AV means aortic valve, the aortic valve is at more or less 9 o'clock. And then the commissure close to the aortic valve is the commissure between the septal and the anterior leaflet. And moving in a clockwise fashion, we can identify the anterior leaflet, the posterior leaflet, and then obviously the septal one, which is the one connected to the septum. You may immediately see that the atrioventricular node is close to the septal anterior commissure. It is marked by this orange marker. You may see also other important structure like the aortic valve, the coronary sinus, and the free wall of the right atrium, which is quite fragile. So we always have to pay attention not to damage the atrial wall when we do our steering with the TriClip device or with whatever device in the right atrium. And the segment that dilate in functional TR are these anterior and posterior segment. So again, the one in connection to the free wall, to the muscular part of the right ventricle. And here you don't see it, but the right coronary artery is surrounding the tricuspid annulus exactly in correspondence of the anterior and posterior segment. So 2/3 of the tricuspid annulus are in close proximity with the right coronary artery, which is lying in the right atrioventricular groove. I will not focus on echocardiographic view of the tricuspid valve because this is the topic of the workshop, so we will discuss a lot. Alex and Greg will show everything, how to image the tricuspid valve. I would just to mention, since we are talking about anatomy, that there is new nomenclature classification that have been published last year. I would just mention that there are a lot of anatomical variation in tricuspid that can be identified quite easily by echo. It's not uncommon that the anterior or the posterior leaflet of the tricuspid are divided in subscallop. So we have a 4-leaflet valve or even a 5-leaflet valve. And usually there is a really high correlation between what we see in 2D or 3D echo and then in anatomy. This is just an example of surgical exposure of a tricuspid valve where the posterior leaflet is really big and bilobated. It's important for people approaching the tricuspid intervention also to have some knowledge of the, let's say, fluoroscopical anatomy of the tricuspid valve. Usually we work mainly in 2 views. One is a steep RAO view, which gives us a kind of perpendicular view to the long axis of the heart and to the tricuspid valve. Use this to steer the catheter perpendicular to the tricuspid valve. And then, as important as the RAO coaxial view is the ANFAS view, which is usually a steep LAO view, so left oblique view, where we image the valve from the ventricle to the atrium. So this is a view where we can recognize the septum on the right. Here is easy because there is also a mechanical mitral valve, so you immediately identify that the septum is separating the mitral valve to the tricuspid valve. And then the leaflet in proximity to the septum is obviously the septal leaflet, and then going in a counterclockwise fashion, because remember that here we are looking at the valve from the ventricle, so not from the atrium. We have the anterior leaflet and then the septal leaflet. Here we have also aortic mechanical valve, and if you remember what I showed you, the commissure close to the aortic valve is the commissure between the septal and anterior leaflet. So we may identify the septal anterior commissure even in fluoroscopy in this ANFAS view. And I think it's really important for navigation to understand how the tricuspid valve is visible in RAO and LAO view. As important as anatomy is to speak the same language with the among the operator and especially among the interventionalists and the echocardiographists. So whenever we navigate and we talk about the tricuspid valve and we steer the device and we want to go above our target, we should be able to avoid any confusion, because maybe you are used to the mitral terminology. Usually in tricuspid, we refer always to the septal leaflet, and then whatever is opposite to the septal leaflet is the lateral leaflet, maybe the anterior or the posterior leaflet. So when we move toward the septum, we will say we go septal. When we go toward anterior or posterior, we say we go lateral. So it's different from lateral in mitral. And this is done by movement clockwise and counterclockwise of the catheter. If we push all the system in, we go closer to the septal anterior commissure, so we go closer to the aortic valve, so we go aortic. If we pull back opposite to the aortic valve, we go in the posterior direction. So there is a slightly different nomenclature when we navigate in the tricuspid. Let's now focus a bit more on the anatomy. This is a pig heart, but it's quite similar to the human anatomy. You see this yellow band marking the tricuspid annulus, and you see the angle between the inferior vena cava and the superior vena cava, which is marked by this blue band, and the tricuspid annulus. You immediately see why approaching the tricuspid valve from the inferior vena cava could be challenging, because the angle between the annulus and the inferior vena cava is really acute. So we need a device dedicated to steer in a coaxial way to the plane of the tricuspid valve if we come from the femoral. Here you see the septum, the translucent fossa ovalis, and now after the opening of the right atrium, you see the surgical view of the tricuspid valve, which is the one that I showed you before, and which is the one that we also see when we perform, let's say, 3D surgical view of the tricuspid valve. Again, in this view, the aortic valve is at 9 o'clock, so on the left of the screen, and you can see the 3 leaflet. This is the anterior one, which is the bigger one usually. Then you see attached to the septum, the septal leaflet, and at 3 o'clock, you see the posterior leaflet. So there are 3 leaflet and 3 commissure in this valve, beside the anatomical variation that I already mentioned you. And the portion of the annulus that dilate are the one in continuity with the anterior leaflet that you are seeing here. You see this big papillary muscle, which is a constant in the tricuspid valve below the anterior leaflet. This is the septal leaflet attached to the septum, and this is the posterior leaflet, which is usually the smaller of the 3 leaflets. As I told you, there are 3 commissure. We will talk a lot about the commissure and commissural line, because these are our target when we perform transcatheter edge to edge, usually the anteroseptal line of coaptation or septo-anterior line of coaptation is our target. You see here the so-called triangle of Koch, which is a virtual, let's say, anatomical structure that we use to identify the atrioventricular node. Is a triangle with 3 sides, and the apex of this triangle is the atrioventricular node. The 3 sides are the implantation of the septal leaflet, the edge of the coronary sinus, and the tendon of Toder, which is this tendon on the right atrium. And you can really identify at the apex the atrioventricular node. This is a reference very important in surgery to avoid any atrioventricular conduction disturbances. Here you see the target of the edge-to-edge therapy in most of the cases, which is the coaptation line between septal and anterior leaflet. Usually we perform an edge-to-edge approximation of these 2 leaflets. Then there are other devices, some of them are already not anymore available, let's say, that target annular remodeling. Actually, when we perform edge-to-edge of the tricuspid valve, we also bring somehow the mural, so the free wall, the mural part of the annulus towards the septum. So we have also an indirect annuloplasty effect. Whatever bring the mural part of the annulus towards the septum, like this kind of annuloplasty approach, is also reducing TR. So TriClip has a double effect: approximation of the leaflet with obliteration of the regurgitant orifice, and indirect annuloplasty effect by bringing the mural part like an annuloplasty device towards the septum, which is actually what is done in surgery most of the time. Now you see the proximity of the right coronary artery. This is the right coronary ostium in the aortic valve, and I'm opening the endothelium of the coronary, and you see how close the right coronary artery is lying to the mural part of the tricuspid annulus. So it's surrounding basically all the anterior and posterior segment of the annulus. So whenever we touch the annulus with a surgical annuloplasty device or transcatheter annuloplasty device, we may impinge the right coronary artery. Here you see this light in the endothelium of the right coronary artery. So you see how close it is. You should be aware that the right coronary artery is really close to the tricuspid annulus. And here we are just puncturing the right coronary artery to see that you can really, in reality, puncture it if you don't pay attention. Now the right ventricle is open. You may see how the subvalvular apparatus of the tricuspid valve is done. You see this is the attachment of the septal leaflet to the septum. There is no a proper septal papillary muscle. So the septal leaflet is getting corded directly from the septum. As you can see, this is why really often is tethered. And here you see this big papillary muscle, which is constant in every anatomical variation. There is always this big anterior papillary muscle, which is also called Lancisi papillary muscle. And usually this is below the commissure between the anterior and the posterior leaflet. So we use also as a marker in echocardiography to identify what is anterior and what is posterior leaflet. And this is always present. It is rising from the free wall of the right ventricle. And then there are usually one or two small posterior papillary muscle, but these are also highly variable. Here you see again the relationship between the right coronary artery and the annulus from the ventricular side. You may also see that in the RVOT, there is this band crossing the outflow, which is the moderator band. In human, this is much bigger, but it's constant as well. Here you see my instrument coming in the RVOT from the pulmonary valve. There is a distance between the tricuspid annulus and the pulmonary valve, which is the infundibulum of the right ventricle. So this is why it's impossible to have outflow obstruction in the right ventricle, because there is this distance. The pulmonary valve is obviously a 3-leaflet semilunar valve, similar to the aortic valve, with a thinner leaflet, but the structure of the leaflet is really similar. And here you see again the distance between the two valves. So there is no contiguity like in mitral and aortic valve in the left ventricle. These are just, we will see the steering maneuver of the device, but the basic steering maneuver in tricuspid, if you come from the femoral vein, is that if you push, you go closer to the aortic valve. If you pull, you go far, so you go in the posterior direction toward the posterior leaflet. And then if you torque clockwise, you go towards the septum, and opposite, counterclockwise, you go lateral, so anterior. These are the 4 basic maneuvers to steer each kind of catheter in the tricuspid, in the right atrium, so the tricuspid valve. And obviously, if you come from above, so if you are coming from the jugular vein, there are some devices, especially replacement devices now coming from the jugular vein. Obviously, everything is mirroring, so the movements are mirroring the one coming from the femur. And I think with this basic of steering, we can conclude the first presentation. And if you have any question regarding anatomy, I'm really happy to address it now. Otherwise, we can address it at the end. Thank you.
Thank you, Dr. Teramaso. Very, very great lecture. And I love the video very much. It's only can, done by the surgery. So everyone, you're free to type your questions in the chat box or unmute yourself to ask questions to Dr. Teramaso. And if you have no questions for now, we can save the questions to the next session, and we still have Q&A sessions after each topic. So if we
can I ask a quick question?
Oh, sure,
to Maurizio, because really I'm fascinated about by your presentation and the anatomy, and when we're doing these transcatheter procedures, as you said, we are aiming at the septo-anterior leaflet creptation usually. So sometimes, however, as you also show, there are sometimes 4 leaflets, 5 leaflets. So can you explain from a surgical point of view why we choose a septo-anterior leaflet? Is it because it reduced the annular dimension more, or is there any other consideration from a surgeon point of view? And if there are multiple, different morphology, type 3B, type 4, as proposed by Rebecca Han, how do you decide where you put the first clip from a certain point of view?
Yeah, a really good question. I think there are several reasons. One, as you said, is that most likely, and there are some bench model tests on beating heart simulation showing that it is the more effective location if you put a clip to remodel the annulus and to reduce TR. And this is obviously related to the fact that usually in the majority of the cases, the main jet in functional TR is located there between the septal and the anterior leaflet. And also due to the fact that you have more pooling on the annulus, as you said. This is the first reason. The second reason is that it's also the easiest to reach with the device. Usually to put a clip in the septal anterior line of captation, it's much easier than to go in the septal posterior and also in the, let's say, anteroposterior. We almost never go in the anteroposterior, but it's the easiest. So all the experience with my TriClip in tricuspid at the beginning and now with TriClip started with this location. So obviously we are lucky because the easiest is also the more effective. And regarding the anatomical variability, usually, even if it could be more challenging because the separation of the different scallop may present like a cleft-like indentation, usually we don't change our strategy unless really the location of the jet is, I mean, if there is no jet in the anteroseptal line of captation, obviously we don't target this, but usually if there is jet there independently from the anatomy, from the presence of adjunctive leaflet, we just go there trying to avoid in distortion of this cleft-like indentation.
Right, thank you. And sometimes when we do even there are jets elsewhere, but if there is a jet in the septal anterior commissures, if you put a clip there, often it can produce reduction of a TR, sometimes in elsewhere, so central or posterior, right?
Yeah.
So, yeah. Thank you. Yeah.
Thank you, Dr. Caramasso. Thank you, Professor Lee, for the questions. Then we will have Professor Scalia on the second topic, per procedure imaging for tricuspid tear, step-by-step approach. Professor Scalia, please.
Very good. Karen, can you hear me coming through?
Yes, yes.
Very good, thank you. All right, well, that's a beautiful talk. Maurizio, I love that talk and thank you for giving it. It really is valuable to see the macro anatomy. Let's have a look now at the imaging anatomy. So, as you'd expect, 3 leaflets of the tricuspid valve are the larger anterior leaflet, which is, as you saw, associated with the right coronary artery in the AV groove, and is the most anterior, obviously. You've got the posterior leaflet, which is associated with the distal part of the right coronary artery, which can have multiple segments, and we're going to talk a lot about segments and this new nomenclature. And then the septal leaflet, which is near to the atrial septum and the inferior vena cava. Now, I very much like, Maurizio, that you refer to the septo-anterior commissure, which I've drawn there in blue, and the septo-posterior. It's very important, I think, we use this language of septo-something. And so in this case, you might want to put some sort of device, septo-anterior, or this one is septo-posterior. I noticed we listened to Rebecca Han today give a talk here at this conference that I'm at, and she referred to anteroseptal and posteroseptal. I think that we've, certainly in our unit, gone with septo-something. I'm also taken by the fact, Maurizio, that you said that you call the composite of these 2 leaflets, you call it lateral, and this thing here is the septal. And what I've been doing is referring to septo-something, septo-anterior or septo-posterior. So you might want to put a clip there, for example, septo-posterior. As we said, you very seldom would want to put some hardware into this anterior-posterior commissure. And I've been referring to this commissure as the divide between anterior and posterior. So there's some language that we're now getting into our vernacular. Further, notice that the septo-anterior commissure is right up here near the aortic valve. That's going to become important in a second. So 3 leaflets, anterior, posterior, and septal. If you look at the right ventricle from the right side and take off the right ventricular free wall, you will see, as has been discussed, this large anterior leaflet. Now this anterior papillary muscle. This papillary muscle is very important. And we learned this today in a lecture we saw by Rebecca Hahn and I think this has helped me a lot, that this differentiates anterior from posterior. And you might say, well, so what? But when you start to get into this business of having multiple, not just 3 leaflets, but 4 leaflets or 5 leaflets, what we learned today was that everything anterior of this pap muscle, everything out here is an anterior leaflet. And if there are 2 of them, then there are 2 anterior leaflets. Everything posterior to this papillary muscle, if there's 1 or 2 of them, is a posterior leaflet. Then there is a small posterior papillary muscle which differentiates this leaflet, which could be single or double, from its septal brother here. As we saw before, there is no single papillary muscle for the septal leaflet, but multiple caudal attachments. And let's have a look at that. And I've tried to show that you can see these very fine attachments to the septum, and then these larger anterior and posterior papillary muscles. Now, as Maurizio showed us, surgical textbooks always have the pictures looking like this, because this is how the surgeons see it with the patient lying down on the bed, with the head of the person being over here and the feet being down here, and you've got this anterior, posterior, and septal leaflets with the triangle of Koch, as you saw there, and that's probably going to give you the AV node somewhere around here. Now, that's not how we're used to looking at it, but if you look at most surgical diagrams, this is how they'll give it to you, and the layout looking like this. But I want to take this diagram and rotate it into the way we look at echo, because how we're used to looking at echo is in the surgeon's eye view for mitrals, which puts the aortic valve right in the middle of the top of the screen. And when you do that, you get this picture here, with a beautiful picture of the septal, anterior, and posterior leaflets. In fact, this is a beautiful picture with the cava down here. And in this particular case, a lovely septo-posterior commissure, a lovely septo-anterior commissure, and the divide there, which is basically this dividing between the anterior and the posterior leaflet. You can also get these images from other forms of 3D imaging. You can get them from transthoracic, but the layout should always be the same by putting them with the aortic valve at the top. Now, as you've seen lots of times, these diagrams from years and years ago tell us that the tricuspid annulus dilates from its free wall. Let's have a look now how this imaging will correlate with our transthoracic and transesophageal pictures. So this is the most important picture. You wouldn't think it, but this is the most important picture that you get in transthoracic of the tricuspid valve. Have a look at the cartoon on the left and have a look at the anatomical features you can see and pay special attention to the aortic valve. Remember, where you see the aortic valve and the atrial septum abutting onto the aortic valve, then you have the non-coronary cusps. Let me just fix this up for a second. Just let me know, everybody, if it's not coming through clearly. Are you hearing clearly, Simon? Yes. So you've got the right ventricle with right ventricular outflow tract and pulmonary valve visible in the top right of the image. The bifurcation of the main pulmonary artery, the inferior vena cava, and the coronary sinus. The coronary sinus is not so visible here. Now, what you're seeing here is the anterior and posterior leaflet. I think there's a misconception that if you see a leaflet that's close to the middle of the heart, that's a septal leaflet. But if you see a leaflet that's close to the aortic valve, that is in fact an anterior leaflet. So this is the AP, anterior posterior leaflets that you're seeing. The septal leaflet in transthoracic is this side of the TV, this side of the monitor, in front of the monitor, and is going wall to wall across the valve, so that it is, you can't see the septal leaflet, but if you could, it would be on this side of the screen and it's wall to wall. And this starts to give you an idea that the septal leaflet has an apposition, septo-anterior and septo-posterior, such that if you drop an X-plane cursor through the septo-anterior, so that blue line on the cartoon is the same as the blue line here, the dotted line here for the X-plane. And what you've got here is the anterior leaflet, and then the leaflet closest to the septum obviously is also always septal, so septo-anterior. And remember, the reason why you're picking up the septal leaflet is because it's wall to wall across the face of the valve. Next, if you move the trackball towards the right of the person, and you can see where the dotted line cursor is coming through now on the index shot here, then what you've got out here is posterior leaflet, and you know that it's posterior because you trackball to it against its septal counterpart, so septo-posterior. Now, in transesophageal, the image is the same but upside down. So in transesophageal, you're, unlike in transthoracic, in TEE, you're looking from above, whereas in transthoracic, you're looking from below. So when you look from above here, you've similarly got the anterior leaflet right next to the aortic valve. The posterior leaflet is adjacent to it, and this is an antero-posterior picture that you're looking at here. And the septal leaflet, which I've drawn in yellow on this cartoon, is behind the valve, so into the TV, and is wall to wall across that picture, so that it's not visible, but if you live 3D and looked into that picture, you would see the septal leaflet wall to wall. Now, why that's important is that if you drop then a biplane cursor or an X-plane cursor through that position where I've got it in green, you've got septo-anterior. And in fact, in this particular case, you can see here this very bad coaptation problem. And then if you move the trackball towards the right of the person, there like this, then you've picked up septo-posterior. And just like we use the trackball with X-plane on the mitrals and go back and forward to look across the face of the valve, then we can do exactly the same thing. And you can see here a huge coaptation gap between septo-posterior. It's obviously a very nasty case. Let's take an example of a case with tricuspid regurgitation. And you can see here, as Alex said, lots of activity going on here, lots of color. And when you look at that, that's the anterior leaflet. So anterior is on that side, closer to the aortic valve. And so the leak in this case is going to be septo-anterior. So let's cut through that. And there it is. So when we cut through septo-anterior, we're picking up leak. I bet, though, that actually if we move this trackball across, we'd also pick up some leak coming towards the middle of the valve, or what I refer to as the divide. The next important view is the transgastric view. Now, in this view, you go into the stomach, you pull the wheel, the big wheel of the TE probe, fairly hard, so that you're looking at the valve in short axis. Now, this is almost always done at plus 30 degrees of rotation, and not at 0 degrees. It's never right at 0 degrees, plus 30 degrees, give or take. And you should get this beautiful view here with respectively septal, posterior, and anterior. And for your reference, you are standing, as you look at this picture, you're standing in the right atrium. So if you could put your finger into the monitor here, and you put your finger through there, you'd be going into right ventricle. So let's look at the anatomical landmarks. You have the septum and coronary sinus visible. You've got the inferior vena cava, which is not visible. It's on this side of the TV. The septal leaflet, the anterior leaflet, and the posterior leaflet like that. And in fact, just here is the divide between anterior and posterior, the divide. This is a turn of phrase that I've been using. And if you're going for a leak here, you refer that to as septo-anterior. If there was a leak here, you'd call that septo-posterior. Unfortunately for us, many of these are wall-to-wall leaks, which are very broad that cross the divide. We'll talk about that, how we handle that in a minute. Now, you can X-plane on the transgastric view. This picture here is X-planing through the septal and anterior leaflet. Is that useful? I'm not so sure. But I tell you what is useful is this. This picture here, by putting an X-plane through the divide between anterior and posterior, gives you a wonderful picture of the papillary muscle. And look at the cords going anterior and posterior. Now, Maurizio showed a slide, and Maurizio, I wonder if you could go back to that slide and bring it up of Rebecca Hahn's classification, because I just haven't got it on this computer, of the scallops or the potential divisions of the tricuspid valve. And when I finish, we'll show your version. But this divider, this papillary muscle, is the divider between anterior and posterior. Now, why is that important? Let's say the division is about there. That's where the papillary muscle is. What we learned is that everything this direction from here is an anterior leaflet. And if there's one of them, then that's one anterior leaflet. If there's a division, then there are two anterior leaflets, A1, A2 maybe. Similarly, everything posterior to the divide, to the papillary muscle, that is, they're called posterior leaflets. And there might be one of them or there might be two. We'll have a look at that picture at the end. This particular case, there's one anterior leaflet, there's one posterior leaflet, there's one septal leaflet, and I'm not sure if this, I don't think this plays, but you can see the color. In fact, this is the one from the lady before where the color is all in the septo-anterior position like that. Yeah. And so our goal in this particular case would be to put the clip there. Let's keep going. Looking from above, in the mid-esophageal view in 3D, septal, anterior and posterior. And in this one, again, a beautiful break point there between the septal and between the anterior and posterior, the divide, which I refer to it as, and this would be a septo-anterior leak, if that's where the leak was, and in fact, that's where the leak is coming from. You can see it there nicely. Let's see if I can freeze frame on that. Yes, I can. Let's freeze that back. So the jet is coming out of here. So this would be an example of what we were going to do in that sort of case. Now let's go a little bit further forward on this one. There's the divide. And this is, sorry, this is another case which has got much more wall to wall. So the first one had jet largely here. This is much more wall to wall. Using the X-plane to find the papillary muscle so we can find the difference between anterior and posterior. There's the divide. Looking at the lower esophageal views, where you can see this jet is pretty much in the middle, pretty much where the divide is. So this is going to be a wall-to-wall jet. And then cutting septo-posterior. There's the divide. Looking at, you've got leak on that side of the divide. And then coming further across, and you might be saying that I haven't come far enough across, and you are correct. The reason I didn't come any further across is as I came further across with the trackball, I was getting a lot of shadowing from this aortic root. And this is a real problem. Imaging in here, close to the commissure, the septo-anterior commissure, you often get a lot of white shadowing from the aortic root. Now, here's a different example of somebody with multiple leaflets, and let's freeze frame this if we could. Nice when it's open. Let's have a look when it's closed. Yeah, there we go. So, in this case, the divide I felt was somewhere around here. And so everything that's posterior to it is posterior leaflet. And let's play it now and just let's determine how many posterior leaflets we've got. Well, you've certainly got one anterior leaflet out here. You've got some sort of posterior leaflet here, and you've got another leaflet here, and then another septal leaflet there. And I'm not sure in my mind, and I'll be happy to be corrected, whether you want to call that 2 septal leaflets or 1 posterior. Now, I'm going to put it out there to the other speakers is, do you really care? And the question about do you really care is this. Look at that. It's one way or the other. Whatever you call all those leaflets, that is a wall-to-wall jet, no doubt. And so you're going to have to figure out where you're going to go. Are you going to go to the aortic side of the divide? Are you going to go to the posterior side of the divide? Are you going to go to both? What are you going to do? So I think that I'd be happy to take advice from the other speakers about the subtleties of this differentiation. But the question is, does it really matter? Because as Maurizio said, it's septo something, septo anterior, septo posterior, and whichever side of the divide you're on, then I think that I'm not entirely sure that it makes a great deal of difference. So I think that at that point I might break out of there. Maurizio, have you got that slide ready with the divisions?
Yes, I can. I can share again the screen.
Yes, let's share that. I just don't have it on this slide set, but it's very important, I think.
Can you see my screen? Yes.
We can, yeah. Yeah, so let's zoom that up. So why don't you just break out of the screen show? Just crack out of the screen show. And just stretch that so it's bigger. Yeah, that's it. Keep going, keep going, keep going, keep going, keep going. Yeah, good. That'll do. So let's have a look at that together. So the blue thing there is the papillary muscle. This is the talk we just had from Rebecca Hahn today. And she noted to us that type 1 is basically what we have in about nearly 50% of people. So type 1, that triangle at the top there, and just point to the blue papillary muscle. Yep. Up in the box A, yeah, that thing. So that's a pretty normal up in the top picture.
Yeah, this one.
Yeah, that's right. So that's the and you tell me as a surgeon that seems to be the standard configuration. Would that be true from what you say?
Yes, it is not uncommon to see C and D, let's say, but this is the most common configuration.
Yeah. Okay.
Which is
so
actually in this report from Becky Ann is 54% of the cases is the type 1.
But look at type 3B or the D triangle there. That's also 32%. That's a lot of people, isn't it? That one.
Yeah.
That one. Yeah. Well, more the D. That's a lot of people.
This one.
And in fact, that picture I think is like, you tell me, and Alex, maybe you tell me, that case, the second case I showed, was that a type 3B that I was showing?
Yeah, I think I want to see whether that septal leaflet, because the septal leaflet is defined as the one that's attached to the septum, right? So you have the papillary muscle dividing the A and the P.
Yes.
So for your case, that leaflet at 12 o'clock seems like it's attached to the diaphragm rather than the septum. So of course, we can look at the image again. So I thought it was a P2. So it's more like a type 3B. But you have you have the leak between the P1 and P2. So yeah, it creates a question whether we should, where should we put the clip? Yeah, can you,
I'll share that. Yeah.
They can stop sharing so you can.
Yeah, I'll share for a second. Let's go here, share, there, and screen show. All right, tell me what you think.
Right, yes, so you see the papillary muscle.
Anterior.
Yep, anterior. And then by Becky's classification, the leaflet, this one would be P1, P, right? Because it divides A from P. So the question is, it looks like a P2 because it's attached to the diaphragm to me.
Yeah, I like that. Whereas this thing here is obviously septal.
Septal, yeah. But the clip seems to be there should be a clip that the leak is between the P2 and P1. There are some leak. It's a wall-to-wall leak. Yes. But the leaks apart from the septal anterior where you have the leak, you also have the leak between the P1 and P2. Yeah.
Okay. All right. Well, I'm happy to hand over there. I've got some cases and things we'll show later on.
Right.
Okay. Yeah. Thank you, Dr. Scaler, and I love your lecture very much, along with the cute cartoons, which show us a very tight close between their anatomy and their imaging. And I think we have a comment here rather than a question. The Dr. Jasper Jason said anatomy is important because it could mean that TriClip is not suitable, but rather for cardio band or other devices. I think it's a comment for your case, maybe. Dr. Scaler, do you think?
Yes, I think you're exactly right. And I in my mind, I was more thinking that when you're in the room and you're doing the procedure, I'm not convinced that whether or not you exactly know where the divide is critical. But I stand to be corrected. But if you're making decisions about going into the room and whether you should be doing some other procedure, I agree completely.
Okay, and thank you.
Can I follow up on that question a bit? So there are some data showing that the gap between the coaptation gap, it's more than 7 millimeter, seems to be like a predictor for success or versus failure for the TriClip. So do we measure the coaptation gap for every case and then make the decision? And where do you measure the coaptation gap? Because Is it the maximal gap, which is usually in the center, or where do we measure it between the septal and anterior where we're going to put the clip? So how do you define it? Yeah.
Well, in fact, we heard this again today, that 7 millimeters or at the most 8 millimeters is the maximum. Having said that, what our approach has been is that if the coaptation gap narrows down, which it always does, down towards the commissure, and we really think that we do want to do the case, we will start near the commissure and zip up down towards the middle. Catch where you can catch and start to bring it together as we go.
Right. So it's not really the maximal gap, which is often at the center. You can have 1.2, but more closer to the commissure, you may have 6 millimeter. Then you can put a clip there and see if it's narrow down a little bit the central gap, and then zip along. Yeah, that's what we do too.
Yep.
Yeah. Great.
Okay.
Karen, you can carry on. Yeah.
Yeah, sure. We have more questions from the audience, and we have another daughter asking, are there any concerns about clipping across 2 scallops of the single leaflet, like across the P1, P2 scallop of the type 3B? I think it's for Dr. Teramaso and Scaler, Professor Lee. And another is, how do we overcome the acoustic shadow generated by the interatrial septum, the aortic valve, and the existing prosthesis?
I'll answer that first, because that's the hardest question of the day. And the answer is sometimes you can and sometimes you can't. So go in, flex the wheel, and try and get up underneath the aorta. If you go down there, sometimes you can get down just enough, put a bit of flexion on with the camera and look up underneath, going sort of around the aortic root. Because remember, here's the tricuspid, here's the aortic, here's the esophagus, and you're looking straight through the aortic valve. So if you can go in a bit and then flex a bit like this and look up underneath, you might get it. But I tell you, like in that case, sometimes you can't. Alex, I'll be happy to be taught new techniques, but there are sometimes I just can't get.
I agree
particularly
with you.
That septo-anterior.
So I absolutely agree. Sometimes it's just impossible. That's why it's so important to use multiple views in tricuspid imaging, whatever views that work, and it may be different for different patients. So for example, we use quite a lot of transgastric, even for the leaflet grasping, we use a transgastric short axis view, because that's probably the view that can avoid that acoustic shadow from the aortic valve, and you can get a good transgastric short axis view in most of the cases. Plus you can have the 3D to do a multiplane reconstruction to get a better transgastric view. And sometimes you use transthoracic echo. So about 20%, 30% of the time, we also use transthoracic echo to see the leaflets, which is particularly important during the grasping. Greg gave you excellent tips about getting the mid-esophageal short axis view, putting a relatively lower position, because you see that on the short axis view, when the aorta is in the center, the right atrium is on the left side of the aorta, which is actually more inferior. So if you advance your probe, you can sometimes able to avoid the acoustic shadow of the aortic valve and avoid the atrial septum, which is kind of blocking the acoustic ultrasound. But my advice is that sometimes don't struggle in the particular view. Use any views you can get in tricuspid imaging.
I think the other thing to say is, if you can't see it, you can't clip it. And you need to get this right before you come in the room. And we won't do anybody as a case who we've not done a screening TEE ourselves. We have to show ourselves, even if they've had one somewhere else not that long ago, we'll do it again ourselves to show that we can get the views, because there's nothing worse than getting in the room and finding that maybe all of the lower esophageal views are no use, or all of the gastric views are no use, or something. So that we need to know in advance, and we will not accept any of these if we haven't done a screening test ourselves.
Okay, thank you, professors, for your great answers to the question. I think the audience should be satisfied. And we should have 5 minutes break here, but seeing the time is so tight, so I decided.
Actually, Karen, before you do, Alex, can you answer that question about, are there concerns about clipping across 2 scallops? Are we allowed to call them scallops, Maurizio? Are they called scallops?
I think we can call them scallops, yes. Segment scallops. Scallops is a terminology from the mitral valve that I would use here as well. I think they are scallop, yes. Rather than leaflet, I don't think are 5 leaflets are like 5 scallop, more than 5 leaflets, but it's just a matter of terminology.
I think if we three decide right here, right now, they're going to be called scallops, that's what they're going to be called for the rest of the world, for the rest of our life. Okay.
Official.
I agree.
It's official. Okay, so
official.
let's say they're called scallops now.
That's what the Abbott supports about the nomenclature for TriClip. Okay.
And now, what do you just see the second last question there, Alex? Are there concerns about clipping across 2 scallops of a single leaflet?
Yeah. Across
the P1, P2 scallop, you wouldn't go P1 to P2, would you? Or would you? Would you go P1 to the septal and P2 to septal or something? What would you do?
Well, I think this question is referring maybe to your cases that maybe there is P1, P2 leak. So my thinking is that you can put a clip there, but I doubt the effect because you're not doing your septal-lateral concept is actually very important, I think, because you are pulling the septal and the lateral leaflet, whatever is A or P, together to shorten the central annular dimension of the tricuspid valve, tricuspid annulus, and that's leading to tricuspid remodeling and etc. And that's, I think, is a very important mechanism for edge-to-edge repair for the tricuspid valve. If you just clip the P1, P2 scallop, it's something like you clip the cleft of the mitral valve itself, and we seldom do that, right? So I don't know whether it is effective or not. I don't have a 100% answer, but that's my guess that I don't think it's very effective. You may have to consider other technique like the bicuspidization technique, where the annuloplasty technique for those cases. Yeah, that's what I think.
Yeah, right. I remember they did one case to mitral valve, mitral cleft. They like put a clip between the the posterior leaflet, the P1 and P2, something like that. So I never see such cases in tricuspid valve here.
Maybe Maurizio can give us some insight from a surgeon point of view. If you see a cleft between P1 P2, what do you do?
Well, you may have to close it if there is, when you do the water test, or if after let's say going off from our lung machine, you see a residual jet in correspondence of a cleft-like indentation. As for the mitral, you may just close it, you may just stitch it. The tendency is to do this only if really needed, because from a surgical standpoint, it's always better to preserve the mobility of the leaflet as much as possible. At least in mitral. In tricuspid probably is less important, but it may be required to close a cleft also in the tricuspid position. Yes.
So is it the same that you close it surgically with stitches versus using a clip? Is there any mechanistically difference with it? What do you think? You will also put a clip there if there is a P1, P2 leak? What do you think?
I don't think I would put a clip there unless, as you said, there are some specific strange anatomy where it's really coming the jet from here. No, I don't think so. I think it's difficult location to get, also difficult to be sure that you have leaflet insertion, proper leaflet insertion. And then the clip is quite big to close this small indentation. I think we have just to pay attention not to open them, not to distort them, like in mitral. We have to put maybe on the 2 sides, being really perpendicular to the line of coaptation, avoiding any distortion. This is what.
Okay,
it's a good point, because sometimes you're putting the clip in those anatomy, you can distort things, twist things. The Clover technique sometimes is not as we can expect. How do you twist the tension there is not as simple as just pulling the septal with the lateral.
And usually also in mitral, if you have a cleft giving regurgitation, what you do, you don't clip the cleft. You put two clips on the 2 sides to close the cleft. So I would use the same approach here as well.
So so another official announcement, don't clip on the cleft.
But there was a case report recently. They put a clip between the 2 scallops in the mitral valve cleft. So one case report, but they said the one procedure success, but there's no. I don't think that's a follow-up data. So we're still observing it.
And I see your note there. I agree with you. I think that I think in these very complicated things, at least at the beginning, we're going to see unreliable or unpredictable results in these very complicated cases. I mean, I think as we get better, do more and more, like with mitrals, we'll take on more and more complicated things.
Yeah, as we were discussing, there are more questions pop up. So another question from the two doctors. The first one is, can the cleft, such as the impartial AV candle, ever be done in tricuspid valve? And the second is, with non-trileaflet morphology, I find that it's more unpredictable post-TV clip. The cleft may open up and require additional clip at septal posterior P1 or septal posterior P2. There's a comment. So, from the Dr. Yu. So let's answer the first question.
So Dr. Yu endorsed our official announcement.
Yes.
They don't clip on the cleft. Thank you.
Yeah. And let's answer the question from another doctor. Can the cleft, such as impartial AV canal, ever be done in tricuspid valve?
I think in partial AV channel, you have the cleft in the mitral valve. The anterior leaflet, the commissures are different, and the anterior leaflet is split in two leaflets. I don't think this has ever been done in mitral position. There are reports of single common valve in, let's say, complete atrioventricular channel where this was clipped, but yes, just some report to my knowledge. Regarding the last comment, there is a study coming from Germany, 2 or 3 centers, showing exactly this, that the procedural success rate in 4 leaflet or 5 leaflet configuration is lower than in conventional 3 leaflet configuration, with no difference in mortality, as expected, I mean, at 1 year, but for sure there is it is a slightly more challenging anatomy if we refer to acute procedural success, so TR reduction, I mean.
Thank you, Dr. Taramasso. So there's definitely no time for break. So let's move to the next session. Let's have a case discussion with Professor Alex Lee. Professor Lee.
Thank you, Karen. Can you see my slides? Okay. So I'm just going to share 2 cases. One is sort of more standard case. Another one is sort of a more interesting, unusual cases. So, okay, the first case is 73 years old gentleman. He is the father of our anesthesiologist. So he presented with heart failure symptoms for 4 years. He has severe obstructive sleep apnea requiring CPAP with poor lung function. So echo shows the patient has a normal ejection fraction of left ventricle, a dilated atria with severe atrial functional mitral regurgitation and functional TR. The RVSP is not too high and mildly elevated. There's no significant coronary artery disease. His lung function is not good, and therefore the heart team decision was that we offer MitraClip for the functional MR and TriClip for the functional TR, either as a combined or staged procedures, depending on we would assess the TR during the procedures, and then if needed, we'll also put in a TriClip if the tricuspid regurgitation is severe. That's something to talk about later, maybe whether a combined or staged procedure should be the way to go. Now, we have therefore performed a MitraClip procedure. So you see, we'll put in a anti-W clip for this functional MR, and then achieve good results. And then we proceed to the tricuspid because the TR remains severe after the TriClip. The RVSP is not too high, so we think that further improvement of the pulmonary hypertension after the mitral clip correcting the MR is probably not going to be too significant to cause a later improvement of the TR. We think the TR is mainly due to tricuspid dilatation as a result of the atrial fibrillation. Therefore, we proceed with the TriClip procedure, and you can see the transgastric view here. It's a large TR, more or less in the center with some involvement of the septo-anterior coaptation line. And this is the use of a 3D echo to better demonstrate the anatomy. So we do a transgastric view, and then we got a 3D data set, and that's how I do it. I put the green plane across the tricuspid valve to be parallel to the tricuspid valve, such as the green plane here would be a, very orthogonal, orthodox tricuspid, the transgastric short axis view, where you can see en face the 3 leaflets. And then we decided that the TriClip should be put here in a perpendicular to the septal anterior line of coaptation, and we try to put it as near the center as possible, because that's where the jet is. And then by putting a blue line here, we can get this reconstructed plane of the sort of grasping view, if you will. You can see the leaflet, the anterior leaflet and the septal leaflet right at the place where you would put the clips. And therefore, I think this is a good way to appreciate the septal leaflet length and any coaptation gap and the anterior leaflet length using this 3D technique, because you know exactly this is the site that you're going to implant your TriClip. Because in the 2D view, sometimes it's difficult to determine where the grasping view you get is actually where you going to put the clip. Then the procedure start with the insertion of the SGC. We start with a bicaval view. It's very important to look at the guide when it enter in the right atrium, because you can see here sometimes distance between the atrial septum and the IVC is very short. And one may used to think that the IVC is sort of parallel to the atrial septum. In fact, it is not. In most cases, it is at an angle, sometimes 90-degree angle to the atrial septum. So once the IVC, the guide entered in the right atrium, it can quickly hit the right interatrial septum. So if the intervention is not looking at the echo, they may actually sometimes injure the atrial septum. And then on this wheel, the implanter rotate the guide away from the septum to create more room for the insertion of the clip delivery system, the CDS, into the right atrium. And the maneuver is just like the mitral clip. We withdraw the guide while creating more room to insert the CDS until we got the straddling. And it's very important to look at this echo view to make sure there's room for advancement of the CDS. So next thing to check is clip arm. Oh, sorry, I think I skipped some slide. Go back. Sorry. Okay, so that next thing is check the clip arm perpendicularity from the 3D on-fast view, looking from the right atrial perspective, and you put the aortic valve in 12 o'clock, and then you get I like to also look at the atrial septum, because that's usually the most obvious structure that you can recognize on the 3D on-fast view. So put the atrial septum at 9 o'clock, and then you get that coaptation line here, and you want to make your clip arm opened and perpendicular to that line of coaptation between the septal anterior leaflet. And then the next thing to use is the transgastric view to examine again the clip arm orientation. So generally, I ask the implanter to advance the CDS closer to the tricuspid valve, and then I go to the transgastric view. And then, because then the tricuspid valve and the clip would be more or less in the same imaging plane, that you can appreciate the perpendicularity better. And then this is the mid-esophageal view, showing the X plane, showing the short axis, the RV inflow, outflow, and also the grasping view here. The TriClip has entered into the right ventricle and then slowly lifted up until the tricuspid leaflets are sitting on the TriClip. And then this case, we decided to use the transgastric view to do the grasping. So I like this view a lot because you can see that when the clip is lifted up, when the leaflet is sitting on the TriClip arms, then you will see that the reduction of the leaflet motion. So here the septal leaflet motion is gradually reduced when the clip is being lifted up, and then after that you see that you can close the clip's arm, and then if the leaflet remains stable, you put the gripper down and close the clip arms to create this dual orifices tricuspid valve. And then you can examine it again through the 3D echo views, reconstructing the planes that shows the dual orifice and also the tissue bridge. Then we check the leaflet insertion, and you can see that this is 3D reconstructed view. This is something Greg taught me in the tricuspid, in the mitral valve, also use it in tricuspid valve. So with the 3D data set, we put the plane just beside the TriClip, and then we measure the leaflet length. It will be the original leaflet's length, the native leaflet length. And then we move the clips, move the red plane right on the clips, and then we measure how much leaflet lengths are still outside the clip. And then we can calculate the difference, and the difference would be the amount of leaflet inserted. It is a rough estimate. I wouldn't say this is like very, very accurate, but it gives us some numbers to work with. I think the most important thing is really to see the leaflet mobility being reduced during the grasping, and also the creation of this dual orifice after the closure of the clips. So this is the result after implanting the first clip. You can see there are still moderate amounts of tricuspid regurgitation at the center. And this is again the X-plane showing by putting the cursor right inferior to the first clip. You can appreciate this is the origin of the residual jets. And this is where we're going to implant the second clip. And then you can assess whether there is still leaflet, adequate leaflet length right here at the residual jet that allow you to implant another clip. And then we proceed with the implantation of the second clip. And here you can see this is a reconstructed plane from the 3D showing the trajectory. So I like to use the 3D to look at the trajectory in TriClip, because in the X-plane and mid-esophageal view, everything's often is out of plane, and only with a reconstructed plane that you can really see the whole length of the CDS is inside the plane, and you can appreciate its trajectory relative to the tricuspid valve. It should be perpendicular to the tricuspid valve in both of these two reconstructed RV inflow, outflow, and also the 4-chamber view planes. And then you can see also the second clip is being inserted just inferior to the first clip. Try to make it as close to the first clip as possible without interfering the first clip's motions. And then because the first clip is already there, that it's it produce more acoustic artifact from me. So I have to really use all the views I can get to make sure that we are catching both leaflets, including transgastric view and the transthoracic echo. And you can see here, the transthoracic echo in this particular case give me a good idea that the septal leaflets is sitting on the clip arms when the clip is being lifted up. And this is finally, we have to use a sort of a deep transgastric view, if you will, creating sort of a 4-chamber view, but from a transgastric position. So I put the transgastric really deep to create a deep transgastric view. And then you can see closure of the clip arms to gradually reducing the leaflet motion of both the anterior and septal leaflets. And final results. So this is a baseline TR. This is after the first clips, and this is after the second clips. You can see almost complete disappearance of a TR, and then the dual orifice, one of the dual orifices becomes even smaller. And if you see this kind of jewel orifice, you know that the liver insertion is good, and there is less worry about a SLDA after you release the clip. And this is the final result. It should be, if it's really implanted well, the two clips should be parallel to each other and moving together, and with the clips, the tip of the clips pointing towards the RV apex, with the very stable clips position and the jewel orifice again. So this is a patient final result, and this is 3 months later. You can see that the TR reduction sustained and patient symptoms improved. He can start driving again and taking care of his grandchildren, and the NT-proBNP also reduced. And this is the WhatsApp message the son sent me, and there was a Christmas time, and he thinks that is really the best Christmas gift he can get for his family. So this is the first case. The second case is an 85-year-old retired metal worker. He has progressive right heart failure in the past 3 to 5 years, and this is his echo. The echo show this patient actually has epsign anomaly. Epsign anomaly is a congenital disease characterized by a apical displacement of the septal leaflets, exaggerated apical displacement. And this patient have torrential TR and with a wide septal anterior leaflet separation. And this is CT showing again this epsign anomaly. And epsign anomaly is characterized by this rotation of the tricuspid orifice anteriorly and superiorly. So it's like an anterior superior clockwise rotation of the tricuspid orifice because of the displacement of the septal, and also in this case, a posterior leaflet, creating this very strange anatomy for a TR procedure. But this patient, right heart failure, has been refractory to medication, and because of his advanced age, it's unusual, but it's possible that the patient with the epsign anomaly present it's very advanced age, because of his comorbidities of also the renal impairment and respiratory impairment. This was heart team decision to offer a tricuspid TR procedure on compassionate ground. So this patient actually has this 4 leaflet morphology, and it would be, I think, is a type 3B morphology, because you see the papillary muscle here, and you see the septal leaflet here. Now this is a view looking from the right ventricle in a transthoracic echo. So you see the papillary muscle here, you see the septal leaflet here, and this is the aorta around here. So this is the anterior leaflet, and this papillary muscle separates these 2 leaflets into A and P, and the cleft here make these 2 scallops, P1 and P2. So you can see that on TEE here in the septal and posterior, they are more deep into the screen because of the septal and posterior leaflet apical displacement, and this is the anterior leaflet. And then there's a wide separation between the leaflets at the center, and this is a CT showing there is a rotation of the tricuspid orifice from its anatomical orifice to becomes more superior and anteriorly rotated. So this is a procedure. At the time of the procedure, we do not have the TriClip available yet in Hong Kong. Therefore, we proceed with a MitraClip system, and we use the Miss-Key technique. So the A knob would be functioning like the deflection of the TriClip, and then we have to use some steering technique to rotate the CDS so that its trajectory is perpendicular to the rotated tricuspid valve. And this is the imaging. So the major difficulties we encounter during grasping of the leaflet is that because of there is a rotated tricuspid orifice and also a wide separation between the 2 septal and anterior leaflets, we were not able to do a successful grasping despite an independent grasping technique that we have already used. we failed to do the grasping because the wide separation. So what we normally do is that we press on the sternum of the patients, trying to reduce the dimension of the separation. But in this patient, it does not work when we put on the sternum because the tricuspid annulus is rotated. So if we're pushing in this direction, there's nothing that we are reducing. Therefore, we ask the interventionist to put his arm, put his hands on the right parasternal region, and then apply a pushing force obliquely towards the patient axilla. So this becomes, the force becomes in line with the tricuspid annulus, which is rotated. And this is the result when we apply this oblique force according to the anatomy. We were able to reduce the septal lateral dimension and approximate the septal and anterior leaflets closer together, and we were able to grasp both leaflets. And this is the result. And you can see here, we create this, we clip the septal anterior leaflet. This is the final result. Still mild to moderate TR, but I think for this 85 years old patients, I think we're happy. And 4 months later, there is significant clinical improvement. It is no longer require 3 diuretics, only require PRN diuretics. And there's a reduction of the right ventricular volumes. You see this on the top is the before the procedure, severely dilated right ventricle, but hyperdynamic. You see the total stroke volume is 118 mil. But I think most of them are these torrential TR. So after the successful TR, there is a reduction of the right ventricular end diastolic volume. There is a reduction of the stroke volume because the TR volume is abolished. And then, but the overall ejection fraction of RV is preserved. So the forward stroke volume is probably increased in this patient after TR. So there is clinical and also hemodynamic improvement in this case. So I think I will stop here. These are the 2 cases I want to present. Thank you very much. We're happy to discuss.
Thank you, Professor Lee. Thank you for your great case. This is a very high-level case discussion, and I used to, use the absent case to shock others. Before I present this case, the mainland doctors always say it's an impossible mission. After they saw that, they often say, well, it's very difficult, and you can do that. It's very impressive.
We're just lucky.
I have 2 questions for you. The first one is, the first case I saw a little bit floppy after you release the devices. So sometimes I was concerned whether the floppy is, how floppy is okay, is acceptable after you release the clips. The second is, TriClip is an off-label use for abstinent abnormality, right? So what's your concern for such cases? So you saw such cases, and why and when you decided to do TriClip for those cases?
Perhaps normally we have only done 1 case. I think that case is after careful discussion in the heart team and also with the patients. Patient did not want to go to surgery, and the surgeon did not want to do surgery on this particular patient because of the comorbidities and advanced age, and because of the severe symptoms refractory to the medication. So we don't think it is, I think the careful planning with imaging is very important. So because you can see that it helps us during the procedures, especially to cater the anatomy of a rotated tricuspid orifice. But of course, I don't think it is a general indication for TriClip. But just to share some experience in some unusual cases with careful imaging planning, sometimes you can do these challenging cases. I'm sure Mauricio will show us even more challenging cases in his presentation. But I think the message here is careful imaging planning. And I think there is Epstein itself. I don't think it's a automatically is a contraindication. It's because there is a high variation in the anatomy in Epstein, from mild to really severe, apical displacement with, delamination and, cell-like anterior leaflet. Those cases probably not suitable. But for this case, mild Epstein abnormally with careful planning maybe is doable. And in terms of your first question about the stability, I think what we look at is to see whether the leaflets, the clips on the fluoroscopy and the echo, whether it's stable. And it's usually, if you see that both leaflets are inserted on the atrial side of the clips and without excessive movement, I think that should be okay.
Thank you, Professor Lee. And we have a question from the audience. And he said, nice pictures in the presentations. And do you use right heart cath routinely? So it is
not before every before every case of TriClip. I think I don't think we do it routinely with right heart cath. In patients with severe pulmonary hypertension, we may need to do right heart cath to clarify the diagnosis of pulmonary hypertension, but not most cases with severe TR undergoing tricuspid tear.
I see. And any comments from the other two professors?
Yeah, we don't usually routinely do it right now.
Yeah, we don't as well, only if there is a reasonable doubt of severe pulmonary hypertension, or for, let's say, study reason, you may need to collect the data, obviously, but otherwise in clinical practice, we don't do it regularly in all cases.
Okay, thank you. Thank you, professors. If there were no questions, oh, okay, there's another question. Can ICE provide additional value in tricuspid intervention, especially when TE images are suboptimal on table?
I think it surely can provide additional value, but I never use it. I mean, I never need to use it. And there is a limitation of ICE because if it's not 3D, that if it's 2D, you may not be able to get the 2D planes that you need for leaflet grasping, for example. Because in ICE, the plane is usually horizontal, so therefore you are not, you're not usually seeing the septal and your leaflet. But with 3D ICE, there where you can reconstruct the 2D plane you needed for grasping from the 3D data set, then I think it would be useful. But I think TE should be able to do most, if not all cases. What do you think, Greg? Do you use ICE?
Yeah, no, so we're not using ICE. We don't have 3D ICE at this stage. I tell you what the problem with ICE is. It's not that. The problem is that we're not doing it. And so you've got the interventional people have to work this equipment, which they're not very used to. They've got some experience maybe, but they're busy. They're very busy doing all of their manipulations of the clip. And people like us who are concentrating only on the echo aren't driving the echo. Now, maybe there's a place, particularly if we get 3D ICE, for people like us to be scrubbing in, being a second operator in the sterile field and working the knobs. Because I think driving an ICE probe is like driving a TE probe. It's exactly the same, to knobs and tilting and twisting and planes and all that sort of stuff. I don't think it's any different. So it's not just that it may or may not be inferior technology. It's that it's got a second pair. It doesn't have the second pair of hands and eyes working it. So that firstly, I think it needs to get 3D, and that's very close to here, if not already. I think somebody's got a 3D ICE probe available already, but it needs to have one of us working it with the experience of working the steering of images, which I don't think is that different. It's just something we'd have to get our skills around.
Okay.
With the current 2D ICE, I have some experience. It could be helpful sometimes if you don't see leaflet insertion, we don't use it for grasping, but if you are in doubt with leaflet insertion and really we cannot see, it could be a complementary tool, or it is really helpful in annular procedure rather than leaflet procedure. You can see the hinge point of the annulus really well. It's not helpful in navigate, obviously, but you can see even the right coronary artery really well, and you can, so for annuloplasty procedure, I think it may have an adding value.
So Alex, we've stirred up a hornet's nest about not doing right heart caths. Two questions there about how can you be sure it's not pulmonary hypertension, either pre-capillary or post-capillary, mostly post-capillary. I think they're suggesting if you haven't done a right heart cath. So what's the answer to that?
Well, we do not do right heart cath for every case with TR, do we? Right? Only when the echo suggests the estimated, for example, TR velocity or the estimated RVSP is high or moderate high. So there are features suggesting this patient have pulmonary hypertension, then we do right heart cath, right? So that's the indication for right heart cath. So if the patient have no such features, meaning the TR velocity is not high, less than 2.7, and then there is no other echo features such as flatten, paradoxical septum flattening or other features suggesting the patient have significant pulmonary hypertension, and then therefore I think many cases can be pretty confidently diagnosed that TR secondary to other things, for example, atrial fibrillation with annular dilatation. So for those cases, I don't think a right heart cath is what we usually do, right?
Okay, and while we're in the neighbourhood, Siwi has asked about right ventricular dysfunction. Sorry to do your job, Karen. Right ventricular dysfunction.
It's okay.
I worry about this. I worry about which right ventricles might be too sick going in, such that when you do the job, you're going to make the person worse. Have either of you folks got cutoffs that you just say, I mean, in my eye, I can see it, but have you got any rules about which ones are just the right ventricles are too sick to do?
And going back to, yeah, go on.
More questions? Yeah, more questions for the audience. And by the way, I'm very happy you take over my jobs. So from the Dr. Yu to the professors, do you have any cut-off value for degree of RV dysfunction or concerns in patients with severe RV dysfunction when planning TV tier? And
let's do that one. That's important.
Professor?
Cutoff value.
Yeah.
I am not aware of a validated cutoff value of degree of RV dysfunction.
Yeah,
but I do worry, don't you?
MRI, you mean?
No, I do worry that some of these right ventricles are too
sure,
sick.
sorry.
Yes.
Yes, obviously this is an issue, but there is not a reliable way to measure and quantify right ventricular function in patients with severe TR. So let's say that in my personal experience is extremely rare with transcatheter edge to edge that you get, even if you get a good TR reduction, that you get severe afterload mismatch. You may think to support temporarily the ventricle with some inotrope if you are worried about this. I think this will be a major issue probably for valve replacement in tricuspid transcatheter valve replacement. But at the moment we don't have a real cutoff. Probably if we need to study better the issue of people say that longitudinal strain is the best way to quantify it. But again, there are no cutoff and there are also no clear prognostic correlation among right ventricular function and outcome in the different studies. But actually, probably because those methods are not the one that we should use, are just inappropriate for patients with severe TR.
I actually think that in addition to the RV function, more commonly we encounter people maybe too sick is those with severe pulmonary hypertension, with RVSP say more than 70. Those cases I've done a few, and I found that the TR often persists after we do the TriClip because of we just cannot decrease the pulmonary hypertension. So the pulmonary hypertension persists, and then the patient still have severe TR, and then the RV still fail. So I think the RVSP, or the pulmonary pressure, is important. So that's why I think the right heart cath question is relevant for those with pulmonary hypertension. It's important because I don't think those with severe pulmonary hypertension treating the TR actually will get them better. Sometimes make them worse. But I don't think we have a magic number of cutoff of the RVSP. I personally think that more than 70 millimillimeter is definitely not. 60 to 70 maybe you can consider, but below 60 is usually most of our cases we have a RVSP below 60. That we'll be happy to go ahead.
So more and more questions pop up. So there were 3 more questions. Which view do you use acquire the real-time NPR, 3D NPR during the procedure? Professor Lee, it's from your PPT.
Oh, that's a good question. 2 views. One is a transgastric, another is the low esophageal view, where we can see the tricuspid valve 2D image nicely, and then we go to the 3D. And when you go to 3D, it's important, depending on your purpose. If you want to look at the trajectory of the TriClip, just make sure your 3D sampling data set also include the CDS, at least, if not also the guide inside your 3D volume, so that you can find the cut plane that is nicely demonstrate the anatomy of the tricuspid valve and the CDS and the guide to show check the trajectory. I find it myself very useful in using this.
I'm just posting on the chat a link of a manuscript that is trying somehow to bring some information on the relationship between right ventricular function and pulmonary artery pressure. There are some data, obviously are not randomized data, but suggesting that the RV pulmonary artery coupling is somehow related with outcome after intervention. So if you have a higher than 0.4 is the cutoff in this study, that means that you have a kind of afterload reserve, and then you have a reduced all-cause mortality in the follow-up. If you have a lower than 0.4 coupling between right ventricular function and pulmonary artery, then this is related to higher mortality. So probably we should take, as you said, in consideration both the relationship of the two.
Yeah, that's a very good point. So it's the RV function and also the pulmonary artery, pulmonary hypertension.
Yeah.
Both, yeah.
The relation of the two,
yeah.
the coupling.
Yeah.
Okay, one more question is for imaging. Do you or how do you use CT imaging for planning of the tear? So professors, do you use CT images for tear planning?
We don't. Even, I mean, most of the time in the workup of the tricuspid regurgitation patient that we want to treat, we do CT scan anyway for other reason, or because we want to screen him also for annuloplasty or for valve replacement. But to plan transcatheter edge to edge is not required. You don't need it. You may get some information. For example, you may measure the chance of having septal lagging because you can measure the angle between the septum and the vena cava. You can measure the distance between the inferior vena cava and the tricuspid annulus. So you may get a lot of information if you look at it, but it's really not required. I don't think anybody is doing planning of transcatheter edge to edge based on CT. If you have it, it's nice to have a look because you can get some maybe useful information, but it's actually not required for the planning.
Agree. We don't use CT routinely. The case I show, we use CT just exactly as Mauricio said. We look at other things, the coronaries and the so it's not for the tricuspid.
Yes, I think the doctor is impressed by your CT images of their Epstein case. So I think last question is still about the right heart cath, and there I think that Dr. Jason is very supportive in performing the right heart cath.
No, we have answered that, but yeah, I now look at Dr. Jensen's whole question more carefully. He mentioned about HFpEF. Yeah. So I just want to make a comment. I do see patients that actually they actually have HFpEF with NT-proBNP being high, with normal ejection fraction, with LVH that fulfilling the diagnosis of HFpEF, actually also have severe TR. And then what I do with these cases that I will treat the HFpEF with medication first, including diuretics, And now we have some drugs like SGLT2 that has been shown to be reducing mortality in patients with HFpEF. So we usually optimize the GDMT first, and then if the TR persists, symptom persists, and then we'll go ahead to consider DHH repair. That's what we do.
Okay, thank you, Professor. Thank you. Well, it's a very good discussion and Q&A session. And next, let's save the questions for the next session. We will have Dr. Teramaso again for challenging cases. Sharing and Dr. Teramaso.
Yes, I will share with you. It's a really quick case, because I think the discussion is even more interesting than showing cases, but to bring to discussion, sorry, I'm not sharing the screen. Now I share the screen. To bring to the discussion one important topic that it is, in my opinion, under considered when we perform tricuspid edge-to-edge, which is the risk of stenosis. This is a case of a patient, 74-year-old female, quite small, with a BMI of 28, several cardiovascular risk factors. Mainly, she got a previous mitral valve replacement. She got a mechanical prosthesis several years ago due to rheumatic heart disease, and this is already something that should, let's say, bring to us a light in, alarm sign. Rheumatic heart disease could affect also the tricuspid. Let's consider also this. So the clinical history is important. So we may have combination of functional, but also some alteration of the leaflet in rheumatic valve disease. She came with pulmonary hypertension, chronic renal failure, and obviously she was under oral anticoagulation because of the mechanical prosthesis, but also because of the permanent atrial fibrillation, which was the main determinant of tricuspid regurgitation. She got annular dilatation for a combination of pulmonary hypertension and annular dilatation due to atrial primary dilatation due to fibrillation. This is the lab, nothing really special. Renal impairment, some chronic anemia, as you can see. She arrived to our attention quite decompensated. You may see there is also pleural effusion. You see the mechanical prosthesis in mitral position. Normocardial atrial fibrillation. And here you see the transthoracic echo. Left ventricular function was not normal, so 45% ejection fraction. Annular dilatation and tethering at the level of the tricuspid valve with a coaptation gap at the transthoracic echo of 9 millimeter. Really severe TR with complete systolic reflow in the hepatic vein, severe pulmonary hypertension, 61, and slightly depressed right ventricular function with also right ventricular dilatation. This is the TOE. In the TOE, the jet was less impressive, was mainly located at the center of the valve. So you may see it's far from the aorta, it's really a central jet. And the patient was assessed by our heart team, and it was scheduled for transcatheter repair. She was assessed as a high risk for surgery. And then we decided to proceed for transcatheter edge-to-edge repair. If we look at the table that we usually, there are different tables, let's say, to guide us in selecting patients for transcatheter edge-to-edge with TriClip. This is probably the most classical one. And we may see that this patient has some elements that suggest us that probably this is for sure we are not in the column of ideal treatment. We are maybe between the intermediate challenging case or the really challenging case, because the coaptation defect was more than 7 millimeter. There is suboptimal imaging due to the presence of mechanical prosthesis in the mitral position. There was some thickening on the leaflet, severe pulmonary hypertension. So according to the classical, let's say, patient selection pathway, this for sure qualify as a challenging case. Our strategy was anyway, since the jet was mainly central, to target the septal anterior line of coaptation with one or two devices. At that time, we didn't have Gen 4 TriClip, so we decided to use the XTR device, one or two. Most likely we were willing to use two, as in the majority of the cases. And this is the fastening of the procedure. The procedure was quite fast, and I would say straightforward from a technical standpoint. Here you see the catheter, the guiding catheter entering in the right atrium. And then the removal of the dilator and the introduction of the TriClip. As Alex said, pay attention in echo, but also in fluoro, not to touch the septum when you do your steering maneuver, and you're straddling first. So now this is the straddling. And now steering towards the tricuspid valve plane. We usually do this in RAO, fluoroscopic view, to check that we point toward the annulus. Then here you see the mid-esophageal view, RV inflow with the X-plane that we use as a grasping view. We are here correcting the clip arm orientation in 2D. You want to see in your grasping view the clip arm, obviously. And correcting the trajectory as well is mandatory, of tremendous importance. Two things: to be coaxial with your trajectory, and then to be perpendicular to the line of coaptation at the level of your target. You can use 3D, like in this case, to orient the clip arm. You can also use transgastric short axis. The advance of using 3D is that you don't need to move the probe if you want to grasp the leaflet in transesophageal. So you don't need to go back, to go down in transgastric and then come back. So in this case, we oriented the clip arm in using 3D surgical view. And then you see we are in the middle of the valve where the main jet was located. It was quite easy to grasp the leaflet. But the main issue was that with one single clip in the middle of the valve, we already got, so we got gradient. We got a gradient of more than 3, which is usually the cutoff that we accept. We got 4 to 5 gradient with the patient under general anesthesia. So there is a chance that when the patient get up, there was a good TR reduction with one clip, but we were not able to put a second clip. There is already sludge in the right atrium. And therefore, we did not accept this clip. See, we are really in the middle of the valve in transgastric. And what we did, we just moved the clip, and I move forward slightly more commissural. And now we close the clip again, more commissural with more residual TR central, but a gradient of 3. So let's say borderline, but something that we accept. Again, sludge in the right atrium, so smoke. And then obviously we didn't put a second clip. Here we are just assessing the leaflet insertion. And we finished this case with a good TR reduction, gradient of 3. And we were satisfied, but not completely, because our plan was to get a better TR reduction. Here is just some crucial step of each procedure. Trajectory and clip orientation. Arm is mandatory. And then I would like just to point out that evaluation of grasping is as important as for the mitral. We should take our time to assess the leaflet insertion, because single leaflet detachment may happen also in tricuspid. So we cannot accept suboptimal grasping just because we are in the tricuspid. And so you see the gradient was 3. In this case, nice leaflet insertion. This is the final result. The patient had a smooth postoperative course. So she was discharged a few days after. When she was awake, the day after, the gradient went up to 4. But the patient had a smooth postoperative course. What I want to point out is that follow-up was not that satisfactory. So from a clinical standpoint, the patient, despite a nice TR reduction, did not improve a lot. And this is probably related to this 3 to 4 millimeters of mercury of gradient. So we should really pay attention to the gradient. In some cases, like in this one, where the leaflets are thickened, there is an history of rheumatic disease. Always measure your gradient and always consider that you cannot use the same cutoff that you use for mitral in the tricuspid position. Again, usually 3 is the one that we use, even if there are no, it's not clinically validated, but keep in mind that gradient could be an issue also in tricuspid. Thank you.
Thank you, Dr. Teramaso, for sharing this case to us. And because we used to say we didn't pay, we don't need to pay much attention to the tricuspid stenosis because when in TR cases the valve area often is large, but your case alert us to that. So I noted that Candy has shared the paper in the chat box, and you just mentioned, and the audience are free to download that. Any more questions, professors?
Maurizio, it's not common to have elevated gradient after TriClip, at least not as common as from the mitral valve, because the tricuspid valve is much larger. And what do you think is the cause that for your case that there is a significant elevated tricuspid?
Yeah, it's really uncommon, as you said. That's why I showed this case, to show something uncommon, but that may happen. In this case, since especially it's uncommon after one single clip, like in this case, with annular dilatation, because the annulus was more than 4, I don't remember, anyway, it was large. I think probably there was some leaflet pathology, some organic pathology at the level of the leaflet that we misdiagnosed. There was a reduced mobility, probably due to rheumatic heart disease that the patient developed many years before. There was some fibrosis. Even we didn't see any commissural fusion or nothing that, but retrospectively, I think this was probably the reason. There was some organic component, was not pure functional TR.
Can we have a look at the slides, Maurizio? We've got a minute, let's put them up again. I want to ask you about perpendicularity. I wonder whether that's the problem. I don't think I fully understand perpendicularity. Alex, I'm happy to take advice here. Just get to a short axis view where you're getting, there was a beautiful 3D picture where you were getting the perpendicularity. Let's keep coming along. And then you showed us the rotation. Yeah, this one. So let's have a look at that. Now, I don't know, you tell me, that picture there looks like about 2 o'clock, 8 o'clock, something like that. Now, do you think that maybe it needed, yes, needed to be, is it possible that some sort of issue with the perpendicularity is twisting the two leaflets as they come together, sort of like this, and that was what made the gradient? And I'm really not sure that I understand exactly where you want to be in terms of perpendicularity. Say when you go to the transgastric, it seems to be the correlation between the 3D is not, yeah.
I think aortic valve is here more or less at 12 o'clock, and we are pointing, let's say, more or less 2 o'clock, 8 o'clock.
Yes, yeah, almost.
We wanted to be perpendicular to the septal anterior line of coaptation.
Yep.
Obviously, distortion may be an issue, and also in this case could have been an issue. I totally agree. But it's really uncommon that one single clip, even if you create distortion, you get gradient. So I really think in this case, probably this was also an issue, a technical issue, but there was something that we missed in the diagnosis of there was something at the level of the leaflet, because with one single clip, it's really uncommon that you get already 4 or 5 gradient, unless you have still severe TR, and then part of the gradient could be somehow related, but usually it's not that high.
Great. Is there a way to fast forward to a transgastric picture with the arms open?
I didn't save it in this video.
Okay,
I just have this one.
Oh, yeah.
But here the clip is closed.
Yeah, okay.
But we didn't have any particular doubt in this about perpendicularity. Usually we spend So that's why I don't think was, but as you said, in some cases, this could be an issue, especially when you go for a second or for a third clip. Yes.
We see that in the mitrals with the XTR, the XT clip, the long clips of the mitrals. If they're not quite right, then you do see this kind of business, and gradients do go high in the mitrals.
Absolutely. Yeah.
So another question related is what clip did you use in this case? Is an XTW?
Was XTR because it was a case before the approval of Gen 4. So it was a XT the narrow. But,
so what's your routine? What's your workhorse clip?
Is XTW. We use I would say 99 as for a first clip. Then the second clip could be an XT or even an NT or NTW, depending on. But the first clip, and this is quite common in Europe. It's different in US. I don't know why, but in US they tendentially use more NT and NTW in tricuspid. In Europe, more than 90% of the first clip are XTW in the triluminate as well. And
Greg, do you use like what?
We've been using XT, but now that listening to this, I think we'll go more to XTW.
We also use mostly XTW. Yeah. So nice.
Okay, thank you, professors. Very nice. And then next, we will have QLab demo 3D analysis of the tricuspid valve. Professor Scaler and Professor Lee will share some interesting cases to us. So, professors.
Okay, Greg, do you have case to share?
Or no, I'll let you go ahead and I'll talk.
Before I share QLab, just want to show one slide to illustrate a point that the previous there's a previous question about. So this is about the steering of the CDS and then the use of 3D MPR. Where should I get the view? So this is the standard explain view. I always find this explain view, Greg, you may enlighten me later, not perfect for checking the trajectory. The reason is, unlike the mitral valve, you can always get the CDS in plane in both the bicommitral and the LVOT views for the mitral because of the position, relative position of the T transducer and the mitral valve. In the tricuspid, the TriClip, this is a cartoon I borrowed from Greg. So even if you're in the correct trajectory, your TriClip is actually coming from plane that is in front of the TV screen. So and for on the right side, again, so it's something like that. So you never get a plane on this RV inflow alvo view that you can see the entire CDS, and which is required if you really want to check your trajectory correctly. So you can see the tricuspid valve is at an angle from the ultrasound beam. So you could never, like the mitral valve, unlike the mitral valve, you would be never able to get a true explain that you can see the CDS in plane in both planes. That's why I rely quite a lot on this 3D MPR. So this is 3D data set that I obtained just from this same view, but I use a 3D zoom and then put over the tricuspid valve and try to get more of the IVC there and a bit of the aortic valve. So just to orientate myself, then I would rotate this plane to be align these blue and green planes with the CDS. And then you can create sort of a more nicer RV inflow, outflow, and also this 4-chamber view where you get the tricuspid valve being seen here, whether you can judge whether it is the trajectory is correct. So I think this images really tell me that the trajectory is correct. Even you can even work with the implanter to tell them if they want to go more aortic, that you can advance the stabilizer. If you want to go more posterior, you can withdraw the stabilizer, or you can do the flexion extension to change the trajectory. And you can also ask them to rotate clockwise to go more septal, counterclockwise to go more lateral, or use the LM knob to make a medial or lateral movement of the clip on this view. So I found this is very useful to check the trajectory and guide the steering. This is a 3D MPR view. And we're going to use the TriClip to show you some data as well. So that's what I want to share.
Beautiful pictures, I agree. And in fact, you're never going to get down the shaft of it in the basal short axis view because you're cutting across it. You're quite right.
Unlike the mitral valve, you can get that view from X-plane most of the time, but the tricuspid valve you really can't. So let me share the TriClip. So Greg, you're welcome to speak anytime you see.
Well, let's talk as we go. These are beautiful pictures, so let's talk as we go.
Yeah. So you see here is a 4-chamber view, and then this is a transthoracic echo. So we can rotate this plane to get the 4-chamber view like this. And then on the other side, you see is an RV inflow outflow view. And then what I do is that I can adjust the blue plane so that it's parallel to the tricuspid valve on both these red and green plane. Then you will get a very nice short axis view. This is looking from the ventricular perspective, if it's a TTE, and you can see beautifully the 3 leaflets here. So you have to recognize some anatomical structures before you can decide which one is septal, anterior, posterior. And I find that aortic valve, although it's set often, we try to put the aortic valve in 12 o'clock, but sometimes it's not easy to find the aortic valve from the 3D dataset image. But the septum is something that I found is very useful. It's quite easy to recognize. You can always see the septum here. This is the ventricular septum, the atrial septum is the same. I put it in the right position, then you will immediately know that this is the anterior leaflet. This is the septal leaflet, sorry. This is the anterior leaflet, and this is the posterior leaflet. You can see that the anterior surface of the right ventricle is usually less flat, but the diaphragmatic surface is usually a bit flat because it's sitting on the diaphragm. So that's another visual clue to help you to identify where is anterior and where is posterior.
So Alex, mag that picture up, just magnify up, go to the controls and
Which one?
Yeah. Go to controls and magnify.
Okay.
Because what I was going to say was, you do that, just that thing, just wind it up a bit. Go back to the full checkerboard. Yep. Now, and good. So get onto that green line in the bottom left picture, and let's drag it up and down and see what it gives us in the top left picture. So as you come down now, this is septo-anterior, stop. So that's septo-anterior. And then as you go further down the screen, septo-posterior. And you absolutely couldn't tell the difference looking at that 4-chamber view.
Right.
The only way you can know, because I remember looking at lots of these diagrams over the last 20 years, and different people would say it's septal, anterior, posterior, 50%, 40%. It's got nothing to do with percent. It's got to do with whereabouts you are in the block and whether you're further towards the diaphragm, point to the diaphragm and at the bottom. Yeah. This is towards the diaphragm, or whether you're further up towards the aortic valve, which is up here. So septo-posterior and now septo-anterior. And on the 4-chamber view, it looks exactly the same.
Exactly, yeah. Very, very good points. So that's why I think 3D echo is particularly important, because you have 3 leaflets. If you really want to identify which leaflets, I use this 3D echo to guide me. So you can even try to, so here is the anterior septal or septal leaflet, septal anterior line of gravitation, right? So you can adjust your plane so that the green plane here is achieving perpendicularity, right? With the line of gravitation between the septal and anterior. And for example, this is probably where you want to put the clip, depending on where the jet is. For example, put it here. This is the perpendicularity, and then immediately on this green plane here, it is showing the plane across this green line. And this is the view that you would be showing that the leaflet length. And if the clip is being implanted, you will see the clip here. And this could be the grasping view. And you can use this to assess the leaflet gap and the also the leaflet length. Because if you just use 2D echo, you may, like Greg said, you could get a 4-chamber view that looks like it's septo anterior, but it may not be septo anterior. And even you get septo anterior, you may be getting somewhere here. So this is also septo anterior, but this is not where you're going to put a clip, because maybe it's too commissure. So this 3D echo really helps you to pinpoint the exact position where you implant the clip, and then you can make the assessment of the leaflet length and gravitational gap, etc.
Has this 3D block got good enough in pixels that we could crop it and show the on-face view of the tricuspid from transthoracic?
Yes. Actually, I have a
Very done one.
Yeah. This is a
one you prepared earlier.
Yeah, prepared earlier. So this is cutting from the right ventricle. So on 2D, on TTE, I found that the picture often looks nicer if you're cutting from the looking from the right ventricle. But of course, you can do this same from the right atrium. But the anatomy is the same. That you get the septum here, and then this is the septal leaflet. And what is this? This is the anterior papillary muscles and the chordae that we're talking about. And this is right between the anterior and the posterior leaflet, the divide that Greg talked about.
That's a beautiful picture. If you freeze frame it, sorry to interrupt, just freeze frame it, then keep talking.
Yeah.
Open. Yeah. Okay. Keep talking. Yeah, that one.
Yeah. Yeah. Right.
Yeah. Beautiful. Yeah, this really can pick out the papillary muscle in this. You know, unless you focus, you don't see it, do you? But it's perfect.
Yeah, you can. Let me go back to this images. One important anatomy that Greg has pointed, I want to show it here in this on this images, is how the anterior papillary muscle is supplying the chordae to the anterior and the posterior leaflet.
Beautiful. Just mag that up.
Yeah.
Look at that.
Yeah, right. So this is the anterior papillary muscles, and you can appreciate that this papillary muscle is supplying is just between the anterior and the posterior leaflet, and you can also see their leaflet insertion of the chordae from these papillary muscles. So this is the RV inflow view, and is equivalent to the TE short axis view that we use for the grasping, the explain view on the left hand side. But it's
can I make an anatomical comment that I think I didn't say during the anatomical, because here is really clear. If you look at this picture, you see that actually, if you are coaxial to the tricuspid valve with your catheter or with your, you are not coaxial with the apex. So this is different,
right? Yeah.
Between right ventricle and left ventricle. In left ventricle, if you are coaxial with the mitral, you point the apex. Here, no. And why I say this? Because you cannot, you should be aware of this. You cannot advance the clip in the ventricle as much as you think, or as much as you do in the mitral, because then you get the contact with the free wall of the right ventricle. Below the tricuspid valve, there is the free wall of the right ventricle, not the apex. So there is not a lot of space. Sorry for interrupting.
That's a great point. So what you're saying is that the long axis of the RV is not perpendicular to the tricuspid valve, especially when it's dilated, right? When the RV is dilated. So if the CDR is usually going in that direction, right trajectory going this direction, actually not towards the RV. Therefore, you cannot go too deep before you actually hit the chordae very rapidly, because you're going to, this is where the papillary muscle is. So yeah.
One more point on this before we go off it. See, you go to the bottom left picture and point to the red triangle there. At the top of the red line, there's a red triangle. That triangle is nearer to the anterior leaflet. Go up to the top right picture. Top right picture. Top right, yep. And we look where the red triangle is. That tells you that there, and therefore the leaflet, which is on the left of the green line, is the anterior leaflet. So just go down, point to the leaflet. No, yeah, there. That's the anterior leaflet. So if you're confused which is which, because it's fairly featureless, isn't it? But that's the anterior leaflet because it's nearer to the red triangle, and the red triangle is nearer to the anterior on the index shot in the lower left side.
That's a good point. Yeah. Okay. Let me show you another pictures, another data set. Okay. Which one do you want to see? Epstein or?
Well, let's go with the degenerative one because you've given us beautiful pictures of the Epstein. So
right. Okay.
And I don't think we've got anybody with big enough muscles to press on a chest that hard in our hospital. So, so let's go with some TE 3D pictures to reconstruct.
Yeah, this is a TE. Let's go to which one? Let me see which one is good. Okay, I like this one.
Yeah, let's go with that. That looks good.
Yeah. Okay, that may be a better one. Okay, this one's probably better.
Yep.
So this is a 3D data set I obtained at the mid esophageal, maybe a little bit low esophageal view, and then put a 3D zoom there, and then get the sort of like selling like a short axis.
And let's mag up and tell us how you did it exactly, because it's pretty fine detail, and everybody wants to know how you do this, Alex. So let's go through it slowly together. Press play. Okay, so this is a usual acquisition. Just checkerboard onto the 3D yellow thing so we can see what that is. Okay, so let's just checkerboard it. Go absolute relative. That's at the top. Yep. Yep. And then press the bottom right checkerboard. Yeah, get that right. Okay, let's have a look and get this nice so that we can get our orientations together. So what, oh yes, I see. Okay, nice. Maybe turn the gain down a bit. Yeah. Okay. That's cool. Okay, so you can see the catheter coming out of the caver there, and you can see the orientation of the device. That's a beautiful picture. Is that full magnification? Yep. Okay, and the atrial septum there. That's a beautiful picture, Alex. That's the full story in one picture. It's lovely. Okay. So, and just point to where the 3 leaflets would lay.
So this is the so this is septum, right?
Yep.
So you can't see the leaflet very clearly, but this is probably where the septal leaflet is.
Yep. Yep.
And then you have the anterior leaflet there, and then there's the posterior leaflet.
Correct. Correct. Okay, that looks pretty good. So let's go back to the quad screen checkerboard. Beautiful. Okay, and tell us what you do now to orientate your planes nicely.
Right. So you see here, this is the IVC, right? Okay, let me magnify a little bit. So this is the IVC. This is the where the guide comes in, and then it already has sort of bent a little bit towards the tricuspid valve. So you can see the anatomy when the guide comes in. Actually, if you don't do anything, you will injure the atrial septum right away, within maybe 3 centimeters from here. So it's very important to look at the echo and make sure that you can avoid that. And then if you now the trajectory is what I'm going to trying to show how I track the trajectory by I would try to align the blue plane to be parallel to the tricuspid valve here, and on this screen also the blue plane parallel to the tricuspid valve.
So it's sort of an annular plane, that thing. It's sort of in 2 dimensions. It's on the annulus, and then you're going down the barrel with both the red and the blue and the green planes.
Right.
Nice. So you drag the red plane now, so it's on the shaft. A bit further, maybe. Yep. Nice. And then drag the green plane so that it's on the shaft. Nice. And that's perfect. And interestingly, and that's a beautiful picture there. Now, if you just move the blue plane up a bit, you'll start to pick up the clip. Yep. There it is. And okay, now look at the axiality or perpendicularity of the clip in that blue picture down the bottom. What do you think about that?
The clip arm perpendicularity here looks like, I think it's so here is the line of gravitation between the septal anterior. So I think
it's pretty good there, isn't it?
It's pretty good. And I will further check it at the transgastric view because you really can see the line of position really well in this 3D view, but this view is more for the trajectory and approximation of the clip perpendicularity. So you can make it like to rotate the clips to like a 2 o'clock, 8 o'clock here. Then I will further go to the deep transgastric using the short axis to confirm the perpendicularity. But you're right that this view, you can check the perpendicularity as a preliminary check. And here you can see the clip. We can rotate.
Like does that help us doing that? How does that help us? Oh, it gives a grasping view there.
There's a grasping view, yeah. So if the perpendicularity is correct, then this will be the grasping view. Yeah.
Yes.
Yeah.
I don't think using that bottom left picture though, you can judge where you want to be like this. You've got to judge it in the bottom right picture, haven't you?
Yes, you're right, because the tricuspid valve is not in the same plane. So unless you move down and up, you can move down and up. So when you see the leaflet, and then you can move down and up to see the relative position. But I don't do it usually. I check the perpendicularity at the transgastric view. When the clip is advanced closer to the tricuspid valve, then you can get the same plane having seen that involved with all the leaflets and also the clip arm open, then you can judge the perpendicularity. So this view is very useful for checking the trajectory because you really can have the clip arm, the CDS like this in this plane, in both planes, in plane that you can check the trajectory using the X-plane. So
it's really beautiful. I think that's a lovely way to do it, and I'm very impressed with that.
Yeah. So this is the IVC.
And you can see straight away that if you push the whole apparatus in, you're going to go more towards aorta.
Yeah.
If you pull the whole apparatus out, you're going to go more away from the aorta. I think Maurice goes,
exactly.
What do you call that? Lateral. I don't know if it really is lateral, but whatever.
Posterior.
And then in the right-hand top picture, that is talking clockwise and anti-clockwise. If you talk clockwise, it's going to go closer to septum. If you talk anti-clockwise, it's going to go away. Can I show my screen for 1 second?
Yeah, sure.
I've got my cartoons up that you showed my cartoons before, which are very nice. So if I just go like this, so in this picture, so that's what you're basically showing us. And don't worry about that message. If we go in there, push in or pull the whole apparatus out, that's, what are we calling that? Posterior or lateral or something? Push the whole apparatus in, going more aortic. I like that. I'm going to use that word from now on. And then on the other side, clockwise is going to do that, and anti-clockwise is going to do that. Okay, back to you.
Right. So there's a beautiful picture, and there's right now another concept about septal hugging. Maybe you and Maurice can comment on this. So the picture you show on the right, maybe you want to show it again. So sometimes there's a condition of septal hugging because the you cannot control the relationship between the IVC and
here you
septum.
mean?
Yeah, you can create a
like
septal hugging. Yeah. So if you're
oh, sorry. Sorry. Just a second.
Yes, rotate, right.
No, grab it. Sorry, just hard to grab with that. Like that.
Right, yeah. So if your CDS is too close to the atrial septum to begin with, which sometimes you cannot control because the IVC is there, you can't control the position of the IVC. So your guide, if sometimes it's very close to the septum, then you have this condition of septal hugging, which is even you can counterclockwise rotate your guide to bring the clip more laterally. The trajectory is not right because it's not perpendicular to the tricuspid valve. It's actually pointing laterally. And this creates some problem during the grasping. So what do we do? Yeah, so with the TriClip system, now you can have the SL knob that can bring the entire CDS laterally without changing, maybe Maurizio and you can talk more about this. Yeah. So
maybe I can quickly show my screen. 1 second. I have one slide just to
Screen
show how it is actually. Greg, your slide show it really well, but this is what we are meaning. You see now you are coming from the septum in this grasping view. Let's say the septum is on the left. We are coming from left to right, so we are not coaxial. So you do L, and this will bring you far from the septum. And then by torquing clockwise, you gain again coaxiality. So you will see your catheter disappearing because you go far from the septum, and then you torque again clockwise, so towards the septum. And this will let you gain again the coaxial trajectory. Maybe I can show you also how the SL knob work. It's really technical, but actually here you see the difference between, this is the movement. So on the left, we have this white structure is the septum, let's say. If the vena cava is bringing you close to the septum by using L, you basically steer parallel to the tricuspid valve plane, far from the septum. And so you can change the angulation of approaching the tricuspid valve. So you go lateral, and then to gain coaxial trajectory again, you torque clockwise. So you bring the tip of your catheter slightly in the direction of the septum, and by doing this, you will get again coaxial trajectory. It's like when you have aorta hugging in mitral, that you give plus to go far from the aorta, and then you torque towards anterior to get again coaxial trajectory. It's the same concept.
And this is very important because sometimes in the beginning, we don't have a TriClip. With the septal hugging, you can get the alignment right. That's usually where the grasping sometimes is really difficult, if not impossible, right?
Exactly.
Yeah.
All right, Alex, we've got about 10 minutes left, I think. Is that right? So well, maybe one more case.
Okay, let me share again.
Is that right, Karen? About 10 minutes left?
Yeah, she said.
Sure,
yeah.
for you, sure.
And have we got questions? Any questions waiting?
No, for now.
Have you got a transgastric 3D to show us, Alex?
Okay.
Because we've done beautiful mid-esophageal. Let's see if there's a transgastric.
Right. This one. Okay.
Let's play and go to absolute.
Right. Let me go to magnified. Now, the first thing I want to talk about in the transgastric 3D is that now this is the 2D transgastric, right, on the right upper. So I start with this 2D transgastric, and then I go and obtain a 3D data set. The problem with this 2D transgastric, although it looks not too bad, but actually it is not, this plane is not parallel to the tricuspid plane. So when the valve is open and closed, it sort of like becomes a little bit of oblique and change into a more like a deep this becomes like the long axis route and the short axis route. The reason is that you see the green plane here, it is not perfectly parallel to the tricuspid plane. So you're cutting like this, and this is what we're showing in the short axis. And sometimes with a 2D transgastric, you just can't get a a short axis view that is perfectly parallel to the tricuspid planes. Therefore, you sometimes cannot see the septal anterior leaflet crepitation line nicely. Sometimes not, at least not throughout the whole cardiac cycle. You can see this nicely here, but when it closes, it just goes out of plane. And no matter how you manipulate your transducer, you may not be able to get a physical 2D plane that is perfect.
Do you fire this at 30 degrees? Start with a 30.
We start with a 30 degrees, but sometimes even that you can get a perfect. So that's when I think the 3D comes into value, because you can get this 3D data set, and then you can in real time rotate this green plane here such that it becomes perfectly a perfect short axis. Then you can see that the line of creptation throughout the whole cardiac cycle. You can, and also here there's the green plane here. You can make a really nice tricuspid short axis build like this. It is better than the there's not too much difference in this particular case, but in some case it will really make a real difference to get the right correct short axis build using a 3D data set.
That's beautiful. And this is a good old-fashioned 3-leaflet valve, isn't it?
Yes.
A single connoisseur. And if we go out there, you pick up the pat muscle, yeah, look at that. Beautiful. Yeah. Picking up the pat muscle there. Absolutely perfect.
Red plane is cutting across this anterior and posterior leaflet, and you see this very nice papillary muscle there. And it is useful when you advance the clip to make sure you're not hitting into the chordae.
That's lovely.
Yeah, papillary muscles.
If you go down the bottom left picture there, just tilt the red one a little bit anti-clockwise, the bottom left picture. Maybe, yeah, like that, maybe a bit nicer. Yeah, that's even nicer.
Exactly. So you have to align the green plane in both the red and the blue planes so that it fits parallel to the tricuspid valve. Then you can get a perfect short axis. And
is there a nice picture in the yellow? Is there a sort of an on-face view in the yellow 3D block to be had? How good is that? Because I often find these are pretty disappointing.
Yeah, agree. We can try to crop it a bit to see what happens. I can't guarantee.
Yep, there.
Okay.
Yeah, crop adjustment.
Sorry, where is the quick wheel?
It's about, oh no, it's just going up the top there. Stop.
Okay, here. Okay.
Middle, yeah.
Okay. Let's try to look at the tricuspid from the RA side. And
there's a lot of rubbish in the 3D block, isn't there? A lot of pixels. Maybe turn the gain down or something. Yeah.
Not too bad.
Let's mag it up and do that thing. Yes. Yeah. Let's get out. Oh yeah, that's nice, isn't it? So that is looking into the tricuspid valve and into the TV is the right ventricle, isn't it? So this is from RA view.
It's from an RA view, yeah.
That's really nice. And in fact, you can really nicely make out that just hover over the 3 leaflets and say them out. Yeah, beautiful. So you can really make out the 3 leaflets nicely and the divide.
And the papillary muscle here.
Beautiful.
This is the papillary muscles.
Wow.
Here, this is the papillary muscles.
Yeah.
Yeah.
Just go around the back of it. Let's have a look at the pap muscle from the RV side.
Yeah.
Yeah, look at gee, it's so obvious, isn't it? Wow.
You can see the chordae going into the anterior and the posterior leaflet. And septal leaflet over here.
And the funny thing is when you look at it, you think, oh, this is a pretty blurry picture, but the data is in there.
Yeah.
That is really nice.
Great. Yep.
All right. Well, we only got a minute or two. Karen, have you got any questions from the audience? There's a couple of questions there.
Yes, there's a quick question. And how do you normally handle the patients missing the day before or meeting in the morning of the procedure? How long are they usually admitted? This is very critical.
So we bring them in the day before, or even the day before, if they need some diuretics intravenously. And they typically are in hospital for several days afterwards. It's not as quick as mitral.
I think it's an important comment because, as we said, the gap between the leaflet is the main predictor of success, and the gap is highly dependent on the preload of the right ventricle. So if the patient we do a screening and then the patient get hospitalized and it is more decompensated, then the gap can be much bigger. So as you said, it may be necessary to do some preparation with the intravenous diuretic therapy to make the procedure easier or feasible. It's a really important point.
Thank you, professors. And since the time is up, so I'd like to do the closing. And thank you, Professor Alex Lee, Professor Greg Gillian, and Professor Karen Muscle. Thank you for your great lectures and the knowledge you taught us. And I love it very much. So, I hope the audience enjoy the online workshop also and equipped with lots of tricuspid tail knowledge. And we will email you a questionnaire afterwards, and the certificate will be sent to you after the completion of the questionnaire. And thank you for attending the online workshop today, and have a nice weekend. Thank you.
And I think you all want to remember that it was here that we decided they're called scallops today. That's it.
Exactly.
Okay. Thanks.
Thanks a lot.
Thanks.
Thanks.
Have a nice weekend. Bye. Bye.
Thank
See you
you.
soon.
Bye.
Bye. Bye. Bye.